Hi everyone, and welcome to our module on adnexal masses. So the adnexa are the appendages of the uterus, so this refers to the ovaries, the fallopian tubes, and the ligaments. An adnexal mass means a mass in the area of the adnexa, and this is a common problem in gynecology. There are lots of causes related to the ovaries. We'll talk about some of these in this video, things like cysts and benign masses, and also ovarian malignancy. And then outside the ovary, there are also lots of causes of an adnexal mass. This can happen from an endometrioma in a woman with endometriosis. This can also happen from a tubo-ovarian abscess, an ectopic pregnancy, or a number of bowel disorders. In this video, we're going to focus on ovarian causes of adnexal masses, and there are some basic principles of ovarian masses that we should review first. So in general, ovarian masses can cause pelvic pain, although they are often asymptomatic, and they can also potentially be detected by physical exam. A very common cause that's benign is a functional ovarian cyst. These are cysts in the ovaries that derive from the follicles of the ovary or from the corpus luteum. The major concern, however, in any woman with an ovarian mass is that she may have a malignant neoplasm. So much of the workup of an ovarian mass and an adnexal mass is distinguishing between a benign functional cyst and a malignant neoplasm which needs to be surgically excised. In women with an ovarian mass, the best first test is a pelvic ultrasound. In cases where the ultrasound is poor quality or non-diagnostic, MRI can be very helpful, but usually a pelvic ultrasound is always done first. And if the ultrasound shows benign findings, and we'll talk about what these are in a little bit, but if it shows findings that suggest a functional benign cyst, then usually the management involves reassurance of the patient, sometimes with follow-up imaging to confirm that the cyst goes away. If, however, the ultrasound shows concerning findings, and we'll also talk about what these are, then usually the next step is surgical removal because the mass could be a malignancy. So now let's talk about some specific causes of ovarian masses, and we'll begin by talking about follicular cysts. Follicular cysts are a common cause of an ovarian mass in a young woman of reproductive age. They derive from ovarian follicles which develop during the first half of the menstrual cycle, and a cyst occurs when one of the follicles either fails to rupture or it ruptures and then reseals. That leads to a fluid-filled cyst. These cysts are usually filled with fluid containing estrogen, and they can release estrogen, and that can cause endometrial growth. So when these cysts cause symptoms, they lead to pain from the large cyst in the ovary as well as irregular bleeding from the estrogen release that is driving endometrial growth. On ultrasound, they have thin walls, they're filled with fluid, and they have no vascularity. This is a picture of what a follicular cyst looks like by ultrasound on the screen here. And they usually require no specific treatment. They're usually self-limited, and they will resolve with the passage of time. In another video, I talk about polycystic ovarian syndrome, but you should be aware that women with this condition have multiple follicular cysts in both ovaries. That's why it's called polycystic ovarian syndrome. These women also have chronic anovulation, which leads to amenorrhea. They produce excess androgens, which can lead to hirsutism, and they also have insulin resistance and diabetes. Besides follicular cysts, the other major type of benign functional ovarian cyst is a corpus luteal cyst. The corpus luteum forms in the second half of the menstrual cycle after ovulation has occurred, and normally it should involute, but if this doesn't happen, it can go on to form a cyst. In some cases, these cysts will produce progesterone. Normally, the corpus luteum produces progesterone, and sometimes if the cyst is functional, it will continue making progesterone. So when this happens, this can delay menstruation because the cause of menstruation is when progesterone levels fall from corpus luteum involution, but if there is no fall in the progesterone level, then menstruation can be delayed. So when these corpus luteal cysts cause symptoms, the classic presentation is pain from a large cyst, a missed period because of the release of progesterone, and a mass on physical exam. These symptoms are similar to the symptoms of ectopic pregnancy, so you always want to check an HCG. Only when the HCG level is negative do you then consider that the woman could have a corpus luteal cyst. And on pelvic ultrasound, these cysts have a thicker wall compared to follicular cysts, and they also have peripheral vascularity. I'll show you a picture of this in a minute. And just like follicular cysts, usually a corpus luteal cyst requires no specific treatment. They're self-limited and they will resolve with time. In women who develop recurrent corpus luteal cysts, they can be placed on combined oral contraceptives, and this tends to limit the development of these cysts. The ring of fire sign is a sign on pelvic ultrasound in women with a corpus luteal cyst. It's identified by color Doppler during an ultrasound exam. Shown on this slide is an image of a corpus luteal cyst. So this is the cyst. It's a black fluid-filled structure. It has a thicker wall compared to the wall of a follicular cyst. And then all this color in the wall indicates blood flow. That's peripheral vascularity. And that's a classic finding in a corpus luteal cyst. It's called the ring of fire sign. You can also see the ring of fire sign, by the way, in women who have an ectopic pregnancy. But once again, women with an ectopic pregnancy have a positive beta-HCG test. Women with a corpus luteal cyst do not. A variant of a corpus luteal cyst is called a luteal phase cyst. It also goes by the name corpus hemorrhagicum or a bleeding corpus luteum. This is a rare form of corpus luteal cyst where there's spontaneous hemorrhage into the cyst. This leads to rapid enlargement of the cyst and the acute onset of pain. The cyst can even sometimes rupture, leading to peritonitis. And on this slide is an example of a hemorrhagic corpus luteum cyst, and you can see that the center is not dark like the previous image we saw. What you're seeing is coagulation of blood in the center of the cyst, and that's why it's filled with this complex structure here in the middle of the cyst. So follicular and corpus luteal cysts are the major types of ovarian cysts, but there is one other type you should know about, and that's called a theca-lutein cyst. When a woman develops theca-lutein cysts, they are usually bilateral, and each ovary usually has multiple cysts. And these type of ovarian cysts are associated with high beta-HCG levels. So they can develop in women who are having a twin pregnancy or a multiple gestation pregnancy. They're also a classic finding in women having a molar pregnancy. They're called theca-lutein cysts because they contain luteinized theca cells with edema. Basically, this just means that the cyst has hyperplasia of theca cells. And these are benign cysts, and they usually regress once the beta-HCG level comes back down to normal. So we've already talked about how in a woman with an adnexal mass, when you're evaluating her for a possible ovarian mass, the best first step is a pelvic ultrasound. If the pelvic ultrasound identifies an ovarian cyst, the next step depends on whether the cyst is a simple cyst or a complex cyst. Simple cysts are very likely to be benign. They're round or oval, they have thin walls, and they're filled with anechoic, meaning dark fluid. This is a picture of a simple cyst shown in the slide here. In contrast, complex cysts can have thick septations. This means there can be walls within the cyst. You can also see elements of soft tissue within the cyst, so it won't just be dark, but there will be tissue elements. Sometimes the cyst can project outward. These are called excrescences. And you can also sometimes see mounds of tissue in the cyst. These are called papillations. And so any of these findings make a cyst complex, and those are more concerning for malignancy, and they often need to be monitored and possibly removed. And so this slide shows a side-by-side example of a simple and complex cyst. So a simple cyst is round or oval, and it's filled with dark fluid, and it has thin walls. In contrast, complex cysts have a funny shape like this one does, and they can be filled with soft tissue elements and walls like this. These findings make this a complex cyst. So in terms of management, if a woman has a simple cyst and she's premenopausal, then you should know that cysts less than 5 centimeters are a normal finding, and they don't have to be followed up unless they're producing symptoms. All symptomatic cysts are usually followed for resolution, but if it's an asymptomatic, incidentally discovered cyst and it's less than 5 centimeters, that can be attributed to a normal finding and no follow-up is necessary. Simple cysts that are larger than 5 centimeters are unusual, and so those are usually followed for resolution over time. In postmenopausal women, the risk of ovarian cancer is higher, so there's different management of simple cysts in this group. There's a small risk of malignancy if the cyst is greater than 3 centimeters. So usually what's done is if the cyst has a size that's less than 3 centimeters, then you check a CA-125 level. This is a marker for ovarian cancer. And if the level is low, then usually that cyst can be considered to be benign. If, however, the cyst is larger than 3 centimeters, then usually it's followed over time. And if it grows in size, consideration is given to surgical removal. And then finally, for complex cysts in all age groups, surgical removal is usually considered. This depends somewhat on the woman's age and what type of features the cyst has by ultrasound and whether they suggest a malignant or a benign mass. But importantly, when the cyst is complex, it's usually not a benign functional cyst. And so here's a table of the workup of an adnexal mass from the White Coat Companion. This is based on the Society of Radiologists and Ultrasound Guidelines from 2019. Like I said before, if cysts are symptomatic, they're almost always followed for resolution, but if a cyst is asymptomatic, then you can follow the algorithm on this slide. So you begin with a transvaginal pelvic ultrasound. If the cyst is simple and the woman is premenopausal, 5 centimeters is the magic number. Above 5 centimeters, those cysts are followed with imaging. Below, there's usually no follow-up because it's a benign finding. In postmenopausal women, 3 centimeters is the magic number. If the cyst is larger than 3 centimeters, follow up with imaging. If it's below 3 centimeters, no follow-up is often required. However, usually you test a CA-125. And if it's high, that raises the suspicion for malignancy. And then, like we talked about, complex masses have solid components and septations, and they're irregular in size. The differential diagnosis for this type of finding includes a teratoma, an endometrioma, and a malignancy. And I talk about all of these things in the video on ovarian neoplasia. And in many cases for complex masses, surgical removal is required. And that concludes our module on adnexal masses.